Welcome to AETCM, the Emergency Medicine channel. Today we are discussing a case about acute myocardial infarction. A 64-year-old male patient was presented to our ER with complaint of left-sided chest pain since last night.
Okay.
Initial assessment, patient was conscious and oriented, obeying commands. Primary survey, airway is patent. There is no pooling of secretions, no stridor or hoarseness. Breathing, respiratory rate is 22 per minute. Saturation is 99% of room air. Auscultation word, there is bilateral equal air entry. There is no Krebs or V6%. Circulation, heart rate is 90 per minute. And BP is 130 per 70 millimeter mercury. And all peripheral pulses are palpable. Disability, GCS, E4, V5, M6. And pupils are bilaterally equal and reactive. Pain score is 8 by 10 is there. Exposure temperature is normal. GRBS 150 milligram deciliter.
And what important thing you missed in primary survey? Okay, so whenever you have a patient, when we are going checking whatever patient it may be, first we will be checking the airway. So if the patient is not responding, immediately we will have to check for the central pulse. Otherwise, we will have to check in the airway. What all things will you check in the airway? How will we know the airway is patent or not?
Ask him to name or talk.
If he is able to complete one full sentence, that means airway and breathing is okay. Otherwise, if he is able to talk and produce a sound out, that means airway is patent. Then what all things will affect the airway?
Any secretions?
Secretions. It can be secretions, or in trauma patients there can be any foreign body, any swellings, any edema or any blood. These things can affect the airway. So in the airway, first we will have to look whether it is patent or not. So this is a chest pain patient and we are discussing about MI. So in such patients, mostly airway might be patent. If they are going to a cardiac arrest, that kind of a scenario, airway might not be patent. Next is breathing. So first we will have to, for checking the airway, first we will have to look at the face of the patient. Then while going to breathing, you will have to first expose the chest. Expose the chest, connect to the monitor, look at the neck. Okay, look at the neck. We are looking, what all things we will be looking in the neck?
There is respiratory distress. Patient,
okay.
raised JUP. And
trachea also you can check. Okay. Then in the breathing, we will be checking for the respiratory rate. Then
saturation.
Then added sounds. Any crepitation. So why you are checking for any added sounds?
In pulmonary edema, there is bilateral basal
so along with MI, if you are suspecting a cardiac failure also, that is there. Okay. Then main thing in a patient with chest pain is that if the patient's saturation is going below 94%, we will have to start on oxygen. So if any point we are seeing like that, start on oxygen immediately. That is the first intervention. Okay. Then circulation, you have told about the heart rate, BP, then peripheral pulses. Also, you will have to look for the CRT, capillary refill time. That is normally less than 3 seconds. That also you will have to mention in the circulation. Okay. And then either in the adjuncts or in the circulation itself, we will have to tell that we placed 2 large bore IV cannulas and we took samples. Okay. Then disability. Disability, what all things we should mention? GCS. Then pupil. In this patient?
Pain score.
Pain score. Why we are checking pain score?
Because if there is more pain, we in chest pain conditions, MI condition, we give for pain relief tablets or medicines. So after that, we cannot relate that if pain is decreasing.
That is to compare from the initial pain. So first he told the patient's pain score is 8 by 10. And after some time, we will have to ask, after giving analgesics, we will have to ask the patient to score it again. Who is scoring the pain? Patient is scoring the pain. So after some time, patient itself will score the pain to another point of. So if you are finishing your duty and somebody else is taking over, since the patient has scored, you will be able, that person will be able to compare. That is the significance of pain score. Then exposure, GRBS and temperature you have checked. Okay, then what will you do in the adjuncts?
Adjuncts, first we take an ECG. Then there is an ECG ST elevation in V1, V2, V3, V4, and then there is reciprocal ST depression in 2-3 AVF lead. Then patient get connected to the cardiac monitor. Then patient have chest pain, severe chest pain, and pain for control the pain we give sublingual sorbitrate 5 mg. Then also start morphine IV 2 milligram. With morphine we give antiemetic metoclopramide also.
Okay, so adjuncts to primary survey, since it is a chest pain patient, we have took the ECG, we took the ECG and we have seen the ST segment elevation. So how will you report an ECG? First we will identify the name of the patient, then confirm the patient's ECG, then we will have to check the standardization of the ECG, then we will have to tell the, how will you start?
Normal P wave.
First we will have to tell the rate. What is the rate? We need to know whether it is tachycardia or bradycardia. Why we need to know that? In an MI scenario.
In inferior valve MI, there is bradycardia will happen. So
why?
Just do vagal stimulation.
Not because vagal stimulation, because the SA node is supplied by the right coronary artery. So if SA node is getting affected, there will be bradycardia. So that's why that we need to look at the rate of the patient. And tachycardia, we should know whether the patient is having tachycardia or not.
In pulmonary edema, patient becomes.
If the patient is restless, tachycardia might be there. And another thing is that if the patient is in tachycardia, the cardiac demand will increase. This patient might require more blood. So if the patient is in tachycardia, we need to plan on reducing the heart rate also. Okay. Then, that is the rate. Then rhythm.
The rhythm
we need to check whether it is regular or irregular. Okay.
Then there is any PR interval prolongation.
First P wave. First check the. After rate, check the rhythm. Then we need to check the axis also. Then after the axis, we will be going to the P wave. Okay.
Then PR interval, QRS complex, ST segment, T wave, in other waves like U wave.
So what will happen? So suppose you are seeing a PR elevation. What will be that? PR elevation can
PR elevation seen in AV nodal block, heart block.
That is PR prolongation. PR elevation can be seen in atrial MIs. It can be seen. Okay. QRS complex. Then
ST segment.
ST segment. T wave. Okay. That is how you should report an ECG. Okay. So this patient where ST segment elevation was in from V1
to V4.
V1 to V4. So what wall it is?
Anterior wall.
Anterior wall. So how will you tell the walls of an ECG?
V1, V2 septal, V1 to V4 anterior wall, with V1, V2, V3, V4, V5, V6 anterolateral wall. 1 AVL is lateral wall, 2, 3 AVF is inferior wall.
Okay, very good. Okay, so this patient had ST segment elevation and also reciprocal changes. Where else will you diagnose a patient is having ST elevation MI? Like what are the other changes? So always a patient with MI might not be having ST segment elevation. What are the ECG changes in an MI? Initial change, what will
Initial there is a tall T wave, then sometimes Q wave is formed.
After that, first tall T wave will come. After that, ST segment will elevate. Then the third change is the Q wave. Q wave means it is already getting infarcted. So it is like somewhat becoming old. That's why the Q waves will come. Then
T inversion.
ST segment will become normal and it will become depressed. Then last change is T inversion. Okay. So other than that, we have some other changes in acute MI. That way, STEMI equivalent changes are also there. So one is new onset left bundle branch block. Okay. So if the patient is known to have a normal sinus rhythm and suddenly if the patient comes with a new onset left bundle branch block, that is also equivalent to a MI. Okay. Another change is there. What is the peculiarity of AVR?
that only lead is inverse.
AVR is actually here, kept here. So the depolarization is always going in the opposite direction. So AVR will always be negative. So P wave will be negative, QRS complex and T everything will be negative. But if we are seeing a ST segment elevation in AVR, what does that signify? That means that the proximal left anterior descending, proximal LAD occlusion is there. So that is MI, that is a bad form of MI. If you are seeing ST elevation in AVR. Okay. Then another thing is posterior wall MI. The posterior wall, we usually miss the posterior wall MI because we will be always focusing on to the anterior wall, lateral wall. So a posterior wall MI.
Lead, again 2-3 leads. Chest leads of 7, 6, 8 put in interaxillary and in the scapular, like chest leads place.
So we'll have to keep the posterior axillary line just below the scapula and also paraspinal region. Then only we'll be able to diagnose a posterior wall MI. Suppose so routinely we won't be keeping ECGs over that area. So how will you suspect a posterior wall MI? By taking an anterior ECG. That is, we will have to check for the V1, V2, V3. If we are seeing an ST depression, V1, V2, V3 is actually opposite the posterior wall. So if you are seeing a ST depression in V1, V2, V3 along with an upright T wave, then we will have to suspect a posterior wall MI, and then in such scenarios we will have to take the posterior ECG. Okay.
That is posterior reciprocal change.
That is the reciprocal change. Okay. Then inferior wall MI, how will you know the vessel involved in inferior wall MI?
80% inferior wall MI, right coronary artery is
supplying. In order to know the vessel which is involved, one easy method is there. In the anterior ECG itself, if you are seeing that, usually what is the ECG change expected in inferior wall MI? 2V3 AVF ST elevation will be there. So if the elevation of 3 is more than 2, then we need to suspect a right coronary artery involvement. In that scenario, you can take a ECG with V4R. That means V4 can be kept on the right side. Or you can keep V1 and V2 in the same position and change all from V3 to others, we can keep it in the other side. Or just V4R you can take, and if you are seeing an ST elevation in V4R, then that is also signifying that it is right coronary artery. Okay. Then how much millimeter ST segment elevation should be there?
0.1 millimeter elevation, that is one small square, with the 2 contiguous leads.
Classically we call it 2 millimeter elevation in contagious leads, and if it is a male who is less than 40 years,
0.2 millivolt elevation, and more than 40 years, 0.2 millivolt elevation, less than 40 years, 0.25 millivolt elevation, and in women's 0.15 millivolt elevation. Millivolt.
Okay, fine. So that is ST segment elevation. So ECG, you have seen a ST segment elevation MI. Okay. What if the ECG was normal? What else will you suspect? Differential diagnosis.
Principal angina.
It can be cardiac and non-cardiac. Okay. Cardiac causes can be principal angina, then
unstable
angina. Non-ST segment elevation MI. Then in hypertensive patients, because of the demand, it can be because of a demand ischemia, demand angina can be there. Then what are the non-cardiac causes? Yes, abdominal causes like gastroenteritis, then esophagitis,
pulmonary embolism.
First we'll talk about the GI causes. Can be gastritis, and sometimes pancreatitis, cholecystitis, everything can be there. Then respiratory causes.
chest pain causes in respiratory pneumothorax, pneumonia, pulmonary embolism, pulmonary infarct,
Pleuritic chest pain.
pleuritic chest pain,
Then vascular causes.
aortic aneurysm, aortic
Dissection.
dissection, പിന്നെ costochondritis,
Musculoskeletal arthritis, costochondritis. Then skin.
herpes zoster.
Herpes zoster. Okay, so these are the differential diagnoses which we will keep, and from the history we will be coming to the sample history. From the history we will have to differentiate between a cardiac and non-cardiac chest pain. So first we have taken an ECG. ECG is showing ST segment elevation MI. So immediately we will have to put IV cannula. And we will have to we will have to take the samples. Then we will have to give the analgesic. So why you preferred morphine and not sorbitrate?
Ideally we give for pain, morphine is the ideal drug.
Thing is, if the patient is having an angina because of a unstable angina or a NSTEMI, that is actually ischemia. This is actually an infarct. So ischemia pain can subside with sorbitrate, sublingual sorbitrate and all. So if it is an NSTEMI, unstable angina and all, you can give sorbitrate. But such pains, ST segment elevation MI, or if there is an infarction, that pain will not subside with sorbitrate. So in such patients, we will have to give morphine. But in which all conditions you won't give morphine?
In bradycardia or hypotension,
bradycardia, hypotension, inferior wall MI, you are not supposed to give morphine. Okay, so this patient you have given morphine. Before that you have given what? Antiemetic was given. Okay. Then if to reduce pain, what are the other agents which we can use? Fentanyl can be used. First, we should check whether the patient is having tachycardia or not. Suppose if the patient is having tachycardia, we need to reduce the rate. That itself can reduce the pain. So you can give some beta blockers and reduce the pain. Okay. Then if the patient is having pain even after giving morphine, you can start on NTG infusion also. Because that is also a vasodilator. So patient's coronary vasodilatation will happen, and that will increase the perfusion, and that can reduce the pain. Okay, so how will you start NTG infusion?
0.5 microgram.
You can start as 5 microgram per minute, or you can start as 0.3 ml per hour. You can start infusion and monitor every. How will you monitor the
hourly BP monitoring?
No, it is actually 15 minutes. We will have to monitor the BP every 15 minutes. And our target is not the BP. Our target is to control the pain. If the BP is very high, then we can plan on increasing. Okay. So what else was done? So cannula was placed, ECG was taken.
Cardiac and loading dose was given.
Okay, we'll talk about loading dose later. Okay, we'll talk about sample history now. Okay.
Cardiac enzymes were sent. Trope is positive. CKMB is 40.6 nanogram.
So, do you think a cardiac enzyme or trope is required in ST segment elevation MI? Not required. Not required. As a part of routine investigation, we will be sending, so we don't have to wait for that. So what if we get a patient like this? First thing, we'll take ECG, we'll give the pain medication, then we'll have to give the stat medications, and then we'll have to inform cardiology regarding planning on doing a PCI. Okay, so sample history.
Secondary survey. Patient is a known case of type 2 diabetes mellitus, dyslipidemia patient, came with a left side chest pain since last night onwards. There is no radiation of pain, no fatigue, no palpitation, and no breathlessness. Only chest pain is present. General examination.
So how was the pain? Left side chest pain?
With sharp object piercing pain, like pain.
How will you know whether it is cardiac pain or non-cardiac pain with the history?
Patient present like with.
First we will have to ask for the site of pain. So patient is telling it as left side chest pain. Then we'll have to ask the onset of pain. Was it suddenly or gradually? How was the onset? Was it secondary to a fall? Like that, we'll have to ask the onset. Then the character of the pain. It is like a stabbing pain or a tearing pain, like we tell in dissection. What is the character of the pain we need to ask? So usually it will be like a diffuse dull pain, retrosternal chest pain in case of an MI. Then, so that is the site, onset, then character, then radiation. Radiating, where all the chest pain can radiate?
Radiate to neck or jaw and left shoulder, upper arm, left upper arm, left back.
Back or epigastrium. Okay. Then we will have to ask for the associated symptoms. Was there associated nausea, vomiting, sweating, these things. Then timing. Is it progressing over time? That is the other thing we need to ask. And anything that is exacerbating or relieving it. What all things will exacerbate it?
On exertion it will...
well, exertion or walking, is it worsening or is it relieving after rest? That also should be asked. Okay.
General examination, there is no...
Then actually in the secondary survey, you will have to ask according to the sample history. Sample history means S is for signs and symptoms. A is for any allergies. M, whether the patient is taking any medications. Then P for past history. L for last meal and E for events. That is how you need to start the secondary survey. So what are things? Signs and symptoms. A for allergies. M for medications. P for past history, last meal and also events related to this one. Okay.
General examination, there is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, no pedal edema. System examination, pulse rate is 90 per minute, BP is 130/70. As soon as 2 is heard, there is no murmur. In respiratory system, airway, bilateral equal air entry is present. There is no V's or Krebs is present. Other system within normal limits. Diagnosis is there is a anterior wall myocardial infarction without any cardiac failure.
Okay. So what all stat medicines did you give for the patient?
For loading dose, we give aspirin 300 milligram, ticagrelol 90 tablet, 2 tablet, 180 milligram.
180 milligram.
Atorvastatin 80 milligram.
Was given. Okay. How was the pain after giving morphine?
Pain, initially pain is 8/10 decreased to 6/10.
Okay. Then what did you do?
Then we advise a cardiology consultation. Then for screening echo done. There is a regional wall motion abnormality was present and a mild LV systolic dysfunction is there.
In case of ST segment elevation, our initial plan is PCI. That is the first plan and that is a treatment of choice. So sending cardiac enzyme, doing echo is secondary only. That is not important. So we our primary aim is to shift the patient to cath lab. So suppose you are working in a peripheral hospital. How will you decide on doing a PCI and thrombolizing the patient?
If it is not in peripheral hospital, PCI is not available, then we give thrombolysis.
Thrombolysis can be, that depends on the time of shifting. So
more than take 120 minutes, we will start in thrombolysis. Otherwise, it is primary PCIs.
So if a patient is having ST segment elevation MI or an acute MI, in such scenario, the treatment of choice is PCI. If we don't have a PCI, then the alternate option, the second option is the thrombolysis. Okay. So if it is in our hospital, our aim is to shift the patient within 90 minutes for PCI. Okay. So if the patient has arrived, we will take ECG, we will put cannula, give stat medicines, call cardiology, get consent from bystander. Within 90 minutes, the patient should be in the cath lab for PCI. If at all the patient is in some other hospital, or if we don't have a facility for PCI, if the patient will be able to do within the next 120 minutes by shifting the patient to other hospital, then do it like that. If not, then we will have to make a decision immediately and start thrombolysis for the patient. So if we are ruled out the option for PCI, then our thrombolysis should be done within 30 minutes. Okay, that is the time for thrombolysis. So what are the agents?
We use streptokinase can be used. That is 1.5 million units in 100 ml NS given IV.
Not 100 ml NS, 50 ml of D5 water. Okay.
Infusion for 1 hour. Or IV.
That is one option. But problem is that sometimes patient can develop allergy or anaphylaxis to that. Okay. Before doing thrombolysis, what should we rule out?
Any history of stroke or past surgery.
So we need to rule out all the contraindication. Any recent history of any IC bleed or any recent last 3 months, was there any history of any ischemic stroke or any GI bleed history or anything that can cause a bleed, that a life-threatening bleed should be ruled out. Okay.
Or other option is human tissue plasminogen active TPA. It is Altiplase. That dose is IV bolus 50 milligram followed by 0.75 milligram clear body weight, but not exceeding 50 milligram over 30 minutes. Then 0.5 milligram per kilogram body weight, but not exceeding 35 milligram over 60 minutes.
And what are the other options? We have this streptokinase is there, Altiplase is there, then tenecteplase is there, Retiplase. Retiplase, how is the dose? Retiplase you can give as 10 mg stat over 2 minutes. Okay, 10 mg stat over 2 minutes, and after 30 minutes you can give again one more 10 mg. So after 30 minutes again 10 mg over 2 minutes. So 2 doses. That is Retiplase dose. Then we have tenecteplase. Tenecteplase is always stat dose only, a fixed bolus dose only for tenecteplase. Even though patient is in MI or in stroke, tenecteplase is having only a bolus dose. So tenecteplase, depending on the patient's body weight, we will be giving. So if the patient's body weight is less than 60 kg, you can give 30 mg bolus dose. If it is between 60 to 70 kg, you can give 35 mg. Okay. Between 70 to 80, you can give 40 kg. Between 80 to 90, you can give 45 kg. And if it is more than 90 kg, you can give 50 mg. That is a tenecteplase dose. Okay. Then what all agents? So we have discussed about antiplatelets, giving the stat dose of antiplatelets, then deciding whether to go for PCI or thrombolysis. Then what are the other agents which we require? Anticoagulation?
No. Anticoagulation can we do? It is by heparin. Bolus dose is 60 to...
So anticoagulation will not be done immediately after thrombolysis. Or after thrombolysis, anticoagulation will be planned only after 24 hours. So anticoagulation is only done after PCI. Okay. So what is the dose?
It is a bolus dose 60 to 70 international unit per kilogram. Maximum is 5000 dose IV, followed by infusion of 12 to 15 international unit per kilogram per hour. Titrate to maintain APTT for 50 to 75 seconds.
Okay. Why we are anticoagulating the patient?
To prevent the reinfection.
To prevent the reinfection, and also for anyway the patient will be in the ICU for the CCU, so we don't want any DVT or any stent blocking, PCI blocking. For that we are doing. Okay. Then similarly we will have to keep a tight control over the heart rate and also BP, heart rate especially to prevent tachycardia, and especially in patients with acute MI in ICU settings and all, these patients are prone for having reinfarction secondary to any straining. Even straining for stools can also cause this one. So we will have to, if at all the patient is having constipation, we need to relieve that also. Okay. Then discharge, what all things should we give in the discharge?
Discharge, first if you give lifestyle modification, cessation of cigarette smoking, alcohol intake, then weight reduction, brisk walking for less than 30 minutes. Then we give dual antiplatelets like aspirin 150 milligram, clopidogrel plus clopidogrel 75 milligram, പിന്നെ atorvastatin 8 milligram, beta blockers and ACE inhibitors and IRB for preventing the remodeling.
Okay. Anything else? Okay, thank you.